everyone. I'm Joko Wang. I would like to welcome all of you to the fifth webinar of APPCS Educational Forum. And today our topic is mainly focused on the adult tetraphthalate, including care and arrhythmia, and also some interesting cases. I think all of you will enjoy this webinar, and this is our last webinar in this year. So we'll switch this webinar to Philippine society. So thank you all. So I would like to start our webinar. Then the first speaker is Koichiro Niwa. Professor Niwa is I think he's a pioneer in adult CST in this area, and I think everyone knows him. So I don't want to waste the time to introduce Professor Niwa. So could you start Professor Niwa's talk?
Thank you for inviting me. I can talk with the status and the challenges of care for adult congenital disease in Asian Pacific. About 1% of newborn babies have CHD worldwide, and the development of cardiovascular surgery and medical care in children, 95% of patients with congenital disease is growing up into adulthood. The number of adult congenital disease in Asian Pacific region is continuously growing. However, number of specialists and facilities for CHD is still small in this region. It's a bit older data, but I can show you proportion of adult congenital disease over congenital disease in children in Asian countries. In Japan, in 1997, already over 50% of patients with congenital heart disease is in adults. Taiwan, Thailand, Korea, about around the 2000, nearly 20 to 30% of the patient with congenital disease is also in adults. So number of the adult is growing year by year in these Asian countries. I can show you the study on the comparative survey of care facilities for adult congenital disease in Asian Pacific region. It was published in 2016, so maybe that the number of data is updated in these 5 years. Group A, divided into Group A and Group B. Group A is at more than 5 HAD specialists in the country, 10 institutes from 6 countries: Japan, Korea, Singapore, Taiwan, Australia, and New Zealand. And Group B, few HHD specialists in the country, usually under 5, and 13 institutes from 5 countries: China, India, Thailand, Philippines, and Pakistan. General characteristics of these facilities is facility type, about 70% is university affiliation, and hospital type is also 70% in general hospital. In pediatric cardiac hospital is just only 1. And ACHD official society was observed in 2, Japan and Korea. It's only 2. Clinical activity in adult congenital disease outpatient clinic. Outpatient setting is in pediatric cardiology is 17 and adult cardiology is 6. Usually the case in Euro or North American countries, most of the ACHD clinic is in adult, established in adult cardiology. And clinic frequency is like this. Most frequently is 2 or 3 times per week. But 1 time per week or 1 or 2 times per month is also frequently observed in these studies. And also ACHD clinic patient load is about average is 40 per week, from 3 to 300. 300 is very big, but the 40 is very reasonable, I think, because the adult congenital clinic is take a time for a patient. Characteristics of adult congenital disease clinic, ACHD patient population, and clinic belongs. The registered patient is about 1,360 per institute in Group A, but 400 per institute in Group B. So the number of Group A is much bigger comparing with Group B. And also in these patients, repair patient is 61%. And cyanotic disease is 13%. It's like this. So, but the departments was ACD division is only 3 in Group A, and the both adult and pediatric cardiology department is about observed about over 70%. It's very frequently. But just only pediatric cardiology department is 3. ACD care providers and other specialists. The number of ACD specialists is 1.2 per institute in Group A, and in Group B, 0.23 per institute, very small. So even in Group A, the number of specialists is very small. So the other specialists, adult cardiologists, pediatric cardiologists, cardiovascular surgeons, interventionists, electrophysiologists, echocardiography specialists, and radiology department specialists is some numbers in every institutions, but usually the case, these are not belong to ACHD clinic. So in general, ACHD departments, the multidisciplinary team approach is very important, but it's not well established in Asian Pacific countries. Interventional procedures, cardiac surgeries, about 35 per year in Group A and 50 in per year in Group B. Group B is a much bigger number, but the reoperation is about 23 per year in Group A, comparing with the 10 in Group B. And also the perioperative mortality is very low in Group A, 0.97%, comparing with Group B, 3.7%. It's a bit higher comparing with Group A. Catheter intervention is, the number is almost similar with in Group A and Group B. I can show you some countries, what about the situation or problems of the adult congenital disease. It's first the Group V in developing countries. Sri Lanka, Vietnam, Pakistan, Afghanistan, Myanmar, Bhutan, Nepal, and Bangladesh. In these countries, CHD care available but very limited. Health care is very basic. Health care is suboptimal. CHD care virtually non-existent or rudimentary, but improving together with rapid economic growth, I hope so. In Group B, India. In India, 180,000 newborn with congenital disease per year. So 10,000 undergo cardiac surgery for CHD per year. So they said that need 200 centers caring for CHD or ACHD. But problem is vast country, limited resources, uneven population, not enough specialized centers, active and organized ACHD centers is very rare at this point of time. Difficult to travel from remote areas for follow-up appointments. However, ACHD registration program started in 2015 at ongoing. And also Group B in Pakistan. Disproportionate representation of regions at the severe end of the spectrum, like pulmonary vascular disease. Neurological and neurodevelopmental sequelae are not rare. Challenge of infection control is a problem, and the association problem is tuberculosis and malnutrition. Group A, Japan. Recently, Japanese Society of Adult Congenital Disease, JASAC, approved ACHD specialist systems, started in 2021. Already approved a training center in 84 centers. And also the 191 ACHD specialists was approved. Background of this specialist is cardiologist in 60, pediatric cardiologist is 93, and cardiovascular surgeon is 38. So in Japan, it's already many cardiologists is very much interested in the field of adult congenital disease. So training institutions is scattered all over Japan, like this. APSAC, Asian Pacific Society for Adult Congenital Disease. It was established in 2008 in Jeju Island and going on. Now it's 18 countries in Asian Pacific region joins APSAC. Very much scattered in Asian Pacific areas like this. And in these 18 countries, only 4 have not ACHD facilities. Iran, Pakistan, Sri Lanka, and Vietnam. Other countries have ACHD facilities. But what about the ACHD, number of ACHD facilities? It's very small. Already I showed that Japan is very much a big ACHD facilities, but other countries, it's maybe, I think it's still under 10 institutions for adult, like the adult congenital disease has facilities. Congress of APSAC, it's always very focusing on the educations, biannually held at the time of APPCS. First Congress was held in 2008 in Jeju Island, then Tokyo, Taipei, New Delhi, Shanghai, Bali Island, and Taipei, and will be held in 2023 in Sev Island, Philippines. And also ACHD Symposium was started in 2019 in Okayama, then followed by Genju in Korea, and maybe in this year Taipei, then followed by Malaysia. And also web meeting for education, conjunction with the JZAC ACHD night. So first one that's started at September 2021. Focus is catheter interventions and followed by arrhythmia, surgery, and pulmonary hypertension. Already 4 times we have. So I can finally show the summary in my talk. Number one is specialized care facilities for adults with congenital disease have been establishing in the Asian Pacific region, but the number of specialists and facilities for ACHD is still small in spite of the growing number of patients. Number two, ACHD is a multi-system disorder, therefore team approach is necessary. However, it is not yet working in most of the facilities. Number three, formal education and training systems for ACHD by official cardiology society are still lacking. Number four, collaboration, research work, and medical support for developing countries have been very beginning. Asian Pacific Society for ACHD is actively moving forward, having Congress, ACHD Symposium, ACHD webinar, and those will surely support developing ACHD field in the Asian Pacific region. Thank you very much for your kind attention.
Thank you, Professor Niwa. So I think any questions? If there's no question, I think I'll move to next speaker.
Good morning, everyone. So let's proceed to the next talk. It's really my greatest pleasure and honor to introduce the next speaker, Professor Insu Bai. Professor Bai is an expert of pediatric EP specialist, and she is dedicated to a lot of development of new technology of intervention. And because her leadership and academic achievement, she has been the president of Korea Heart Rhythm Society, and currently the president and CEO of Pediatric Heart Association in Korea. And I think it's really wonderful to have a great overview on the arrhythmia in ACHD given by Professor Bai, because she is also a pioneer to develop the whole EP study in the ACHD patient. So the talk today will be arrhythmia in ACHD. So please join me to welcome Professor Bai.
Dr. Wu, thank you very much for the kind introduction. I prepared the video slide, but the volume is quite low, so I'm sorry for that, and please volume up for the individual phone. The potential contributory mechanisms leading to the arrhythmia and sudden cardiac death in repaired tetralogy fellow are shown in this figure. Persistent or residual permanent stances and permanent regurgitation, and the right atrial and right ventricular dilatation and surgical scars provide the substrate of late electrical instability of arrhythmia, such as atrial tachycardia, ventricular tachycardia, and sudden cardiac death. This is a well-known figure showing the increasing tendency of arrhythmia burden in adult tetralogy fellow. Almost 40% had sustained atrial tachycardia in their 50 years of age, and VT was found in 7 to 10% in adult age. In this talk, I will discuss about the atrial tachycardia and conduction block and the role of CRT and the VT in adult tetralogy fellow. and I will present the summary of new AHA and ESC guidelines of VT therapy and sudden cardiac death prevention. Atrial fibrillation and atrial flutter (IRT) are known to be a predictor of death and hospitalization. Bigger right atrial size, tricuspid valve regurgitation, and older age are the risk factor of IRT. However, for the AFib, older age and reduced LV ejection fraction and left atrial dilatation and hypertension and number of cardiac surgeries were known to be the risk factors of atrial fibrillation. The optimal approach to treat atrial arrhythmia in patients with tetralogic furrow continues to evolve. Initially, the rhythm control management is performed over a rate control strategy. Anticoagulation may be considered. However, ESC guidelines identified the lack of a dedicated scoring system to assess the need for anticoagulation. There is an important gap in knowledge. None addressed for the patient with a high CHAD vascular score or low Hess-Brad scores with atrial tachycardia. Anticoagulation should be recommended to prevent thromboembolic complication. For antiarrhythmic drug, beta blocker or class 3 antiarrhythmic medications have been used. In general, catheter ablation is more effective than antiarrhythmic drugs for the treatment of atrial flutter or IRT. Catheter ablation is recommended for symptomatic and drug-refractory IRT or focal atrial tachycardia as class 1 indication. This procedure can be considered as primary therapy as class 2A indication. atrial pacing can be considered to decrease the recurrence of atrial tachycardia or atrial flutter with the sinus node dysfunction. This is a representative ECG showing 2:1 conducted IRT in tetralogic furrow or pulmonary atresia with VSD. The post-surgical tetralogic furrow patients usually show multiple atrial tachycardia mechanisms or multiple circuits. The cable tricuspid valve isthmus and the right atriotomy scar isthmus account for the majority of IRT in tetralogic furrow. This is coherent activation map shows two types of IRT circuit. Left side video clip shows the circuit of CTI-dependent atrial flutter, and the right side figure is showing the circuit of right atrial scar isthmus dependent reentry. The narrow isthmus of circuit is the target ablation lines. Catheter ablation for atrial arrhythmia in tetralogic furrow has a high success rate and low recurrence rate, although some patients require a second procedure. This is another patient voltage map of a 48 years repaired tetralogic furrow. She had recurrent IRT. As you see, the area of low voltage zone and scar was larger. We made 4 ablation lines for this patient. However, 3 years later, she had atrial fibrillation, and we conducted the Cox-Maze procedure and we do pulmonary valve replacement surgery. As this patient, the arrhythmic substrate may progress and the rhythm condition and mechanism may be changed. Concomitant surgical ablation for atrial tachycardia is an effective option in whom undergo the surgical repair. Transcatheter ablation of atrial fibrillation can be performed safely, but the probability of a durable success is lower in patients with congenital disease. The recurrence rate is reported as high as 60% in 1 year. Seven to 9% of patients require pacemaker implantation. CRT was accomplished with a success rate comparable to those with acquired heart disease, despite the complex anatomy and the technical challenges frequently encountered in this population. In patients with heart failure and low left ventricular ejection fraction less than 35% who require pacemaker, pacing burden more than 40%, the biventricular pacing CRT upgrade is highly recommended. However, still we have a limited experience on the right ventricular pacing with RV dysfunction and the right bundle branch block. This is a case report on CRT in tetraphyseal with severe right ventricular dysfunction and VT. The right bundle branch block patient usually shows contraction delay at the anterovagal and alveoli area with respect to the septum. In this case, the latest activation area was guided by high-density 3D-dimensional activation map, and CRT was successfully applied in this patient. After biventricular pacing, the QRS widening and symptom improved. However, there was no change of right ventricular ejection fraction in 6 months follow-up. Obviously, more experience and the data on this issue are required. I'd like to move on the issue of ventricular tachycardia. Almost 19% of VT in tetraphyseal is poorly tolerated polymorphic VT or VF. However, multiple investigations found the monomorphic ventricular tachycardia is the predominant form of ventricular arrhythmia. The mechanism and the substrate of VT in repaired tetraphyseal is alveoli macro reentry with critical isthmus. Radiofrequency catheter ablation or surgical ablation are targeting these isthmuses. The 4 potential anatomic isthmuses for ventricular tachycardia are indicated in this figure. Because of this clearly definable substrate of macro reentrant ventricular tachycardia and acceptable ablation result, the radiofrequency catheter ablation is recommended as class 1 indication for the recurrent sustained monomorphic VT or recurrent ischemic shocks for ventricular tachycardia in the new 2022 ESC guideline. They recommend VT ablation procedure in specialized centers with possibly collaboration with adult EP team. This slide shows the representative growth specimen showing 4 isthmuses. Among them, because of the narrowest dimension, isthmus 3 is the most common target of ablation line. However, overall, procedural failure encountered 28%, maybe due to the hypertrophied myocardium or overlying prosthetic materials. These isthmuses can be identified by catheter mapping using stable sinus rhythm using 3D-dimensional mapping system. Transection of critical isthmus can be shown to result in low rate of VT recurrence if conduction block across the isthmus can be achieved. By historical comparison, the rate of sudden cardiac death in adult tetraphyseal are at least 20 to 30-fold higher than the general population, and the reported rate of sudden cardiac death in tetraphyseal is 0.9 to 1.5 per 1,000 per patient years, which means almost 5 to 8% in 50 years. multiple investigations for prediction of sudden cardiac death and VT have been reported. This table is a summary for the risk factors: older age, prior shunt, ventriculotomy, and non-sustained ventricular tachycardia. Heart failure or arrhythmia symptom, and ventricular dysfunction, and the QRS widening and fragmented QRS. Extensive IV scarring are the risk factors. We should evaluate about all the factors on adult tetrahedral patient at our clinic, and for the patient group of low risk, we can follow annually. However, for the intermediate risk patient group and symptom with multiple risk factors, diagnostic EP study with ventricular stimulation test for VT induction is recommended. And for the patient with high risk, the ICD can be considered. This table summarizes the guidelines of ICD therapy. In addition to the well-known ICD indication, for the tetrahedral patient, ICD is recommended as Class 2A indication with multiple risk factors. At the 2022 ESC guideline, the patient with arrhythmia symptoms or a combination of other risk factors and the positive programmed electric stimulation study result, ICD is recommended as a 2A indications. This is the algorithm for the management of sustained ventricular arrhythmia in patients with congenital heart disease. Anatomical and hemodynamic evaluation is the first step. And for the patient with stable monomer PVT, catheter ablation is indicated. For the patient with unstable VT or VF or very complex heart condition, ICD should be considered. This is algorithm from the 2022 AHA scientific statement. The approach is much similar to ESC guideline. The essential step is the substrate management of VT circuit and the risk identification of sudden cardiac death. In conclusion, ablation therapy is effective for sustained atrial tachycardia. The isthmus-dependent monomer PVT between identified anatomic barriers accounts for the majority of VT in repaired tetrahedral and provides a target for effective catheter or surgical ablation. The risk stratification for primary prevention ICDs remains challenging in adult TED. Further study is needed to get answer. Is ablation sufficiently protective so that some high-risk patients can avoid the need for primary prevention ICDs? Thank you for your attention.
Thank you, Professor Bay. Thank you for the wonderful talk, covered so extensive all the spectrum of arrhythmia in repair of tetrahedral load. And I found this, there's no question on the line, but I wonder, do you have anybody have any questions? Tetrahedral load is the most common cyanotic CHD, not only in neonate, but also in adult congenital heart disease. And as the patient grow older, more and more arrhythmia, particularly atrial arrhythmia, increase rapidly.
Yes.
And very difficult to treat. I think the best strategy is to prevent. Is to prevent, to improve the hemodynamic, or to have some elective intervention prophylactically. but I don't think the prophylactic ablation is helpful. And do you have any comment for the role of prophylactic ablation, such as during surgical, if the patient did not have any atrial fibrillation or no atrial arrhythmia, and somebody suggested if the patient would receive surgical PVR, and they would recommend a prophylactic ablation along with the surgery. Do you have any comment on for this kind of discussion?
Yes, in terms of atrial arrhythmia or tachycardia, any symptomatic patient not documented atrial tachycardia, but the patient have any symptoms, we may proceed pre-operative EPS, and we can map the circuit or possible circuit osmosis, and we can ablate before surgery or during surgery, or right side MAGE can be conducted concomitantly with pulmonary valve replacement or a trachea valve repair during those procedures. For the patient group with some palpitation with non-sustained ventricular tachycardia, VT prophylactic VT ablation has more controversial, because pre-operative ventricular tachycardia induction is not, it has been approved. It's not matched clearly completely to the post-operative VT occurrence. So there is debate on the prophylactic VT surgery during PVR, but for the patient with the percutaneous pulmonary vein implantation patient, they're going to have a large stent at the right ventricular outflow tract. So those patients we need to consider the pre-procedure APA study to document the possible osmosis and the VT induction. For those patients, we can proceed pre-intervention ablation, but no enough data we have. Yeah.
Thank you. Yes, Claire, you have raised your hand, please.
Oh, Claire.
Yep. Yes.
That was a beautiful talk, Dr. Bay. Can I ask, we have seen in the recent guidelines that there is quite a lot of focus on late gadolinium enhancement on MRI.
Yes.
And we are having discussions in our center about how often we should look for this in our patients. And I wonder if you had any comments on this for us. Thank you.
Yeah, thank you very much for your very good question. But yeah, by late gadolinium enhancement study or virtual mapping, there are many patients have delayed enhancement at right ventricular outflow tract and the right ventricular fever or RV insertion site. But the clear correlation between the actively functioning osmosis or damage the myocardium to be gonna be focused the late ventricular tachycardia or ventricular fibrillation is not clearly defined. So that could be one risk factors for the possible late VT or sudden cardiac death. But the location and size and the correlation between the electrical condition is not completely understood. Yeah, so it's one factor, I think.
Thank you. And there's another question from Jonas from Philippines. And the question is, what are the best preventive surgical recommendations to avoid arrhythmia in adult TOF patients? Have you seen an increase of VT in patients who have percutaneous PVR versus surgical PVR? I personally feel this is an unfair comparison
Yes, yes.
Yeah, because surgical
Mm.
PVR, the indication is a little bit different from percutaneous, but please, yes, database.
Yeah, yeah. Yeah, again, we don't have enough data to discuss these issues clearly. The question is about the
What are the
added to redo procedure, PBR or PPBI?
no,
Not the
I think
primary.
I think I think the key issue is, have you seen an increase of VT in patients who had percutaneous PVR versus surgical PVR? And we don't have experience in increase in VT in patient receive surgical PVR, but not for after percutaneous PVR. But just as you mentioned that because the indication of surgical PVR is a little bit different from percutaneous PVR, so sometimes I think it's a little bit unfair comparison.
Yes.
Yeah,
I agree. Yeah.
Yeah, and then the second question from journalists is in the OPD's clinic, what are the important risk factors to monitor to check arrhythmia, road, or danger for VT? I think the key issue is how to monitor the arrhythmia risk or do the risk stratification in OPD patient.
Yes, in our everyday patient clinic, we need to check the possible sort of risk factors such as RV volume and ECG QRS widening, fragmentation, and the degree of pulmonary valve regurgitation, and additionally, patient symptom of arrhythmia, and we need to check the treadmill test or Holter monitoring to get the issues, the data on the possible medical premature beat or non-certain BT. In those patients, we need to perform the invasive EP study to by program the ventricular stimulation test. We need to document the inducibility of VT or VF. Yeah. We need to.
Yes, Professor Chu.
I have a little comment about in our previous experience for a patient after surgical PVR, the VT risk in around post-op around 6 months is pretty high. So maybe another surgical incision may trigger some arrhythmia attack. And for the patient with transcatheter PVR, we didn't see any case of a VT in the 6 months after transcatheter approach, and in around maybe nearly 100 cases. So I think because the transcatheter PVR, we didn't add another surgical incision, maybe there is a little risk of arrhythmia, but I think that database says maybe another large-scale study is necessary to clarify this issue.
Yes,
I
agree with Dr. Chu's comment, but in our institute, the ventricular monomorphic ventricular tachycardia did not increase after pulmonary surgical PVR. Another issue we should concern is the coronary vessel conditions. After multiple do or redo PVR, some patients have a coronary arterial course is just between the artificial pulmonary valve and the aorta, and some of them has compression of adhesions, and so surgical procedure to perform the pulmonary valve replacement surgery, some patients are gonna have a coronary vessel injury that will give the risk of additional ventricular arrhythmia, usually immediately after operation.
Thank you. Because the time is up, so we need to proceed to the next talk. And next talk will be moderated by Dr. Claire O'Donnell from New Zealand. Yeah, Dr. Claire, please.
Thank you very much, Mei-Wan, and thank you so much for the invitation to be part of this wonderful session. I bring you greetings from Auckland, New Zealand. It is my very great pleasure and honor to introduce my friend and colleague, Dr. Chunwei Liu from National Taiwan University, where he's an assistant professor. He has a great deal of clinical expertise and also is always a very wise speaker. He has expertise in adult congenital heart disease, also arrhythmia electrophysiology. And today he's going to speak to us about the very important topic of tetralogy of Fallot and pregnancy in women with repaired tetralogy of Fallot. So Dr. Liu, thank you very much. We look forward to your talk.
Thank you, Claire. Today my talk is about pregnancy in repaired tetralogy of Fallot. Could you see my slides? Okay. After repair of tetralogy of Fallot, the 40-year survival rate is around 90%. Therefore, a lot of female patients can have achieve the pregnancy age. Generally speaking, pregnancy is in low risk and usually well tolerated for women with no significant residual defect or with good ventricular function. The WHO pregnancy risk class is class 2. However, some female patient has residual hemodynamic abnormalities such as a significant PR, significant PS, LT root dilatation, ventricular dysfunction, or some rare cases have pulmonary hypertension. And just as Dr. Bay said, many patients have arrhythmia. These are possible risk factors during pregnancy. And of course, there are some obstetrical or fetal risk. And tetralogy patients have some genetic considerations. We will first look at the general outcome in these patients. We can see the cardiovascular event occurs not very common in these patients. It's around 8%. Mostly are arrhythmia and heart failure. But we have to notice that there are a lot of offspring events. It can achieve about 1/3, including SGA, small for gestation age, prematurity, mortality, or recurrence of CHD. Why is the occurrence of offspring events is so much? We will discuss it later. The paper also found that the cardiac medication before pregnancy is an independent risk factor for cardiac events and also offspring events. And they also found cardiac events are associated with small for gestation age. We familiar with that the pregnancy will induce cardiac adaptations such as arterial dilatation, increased blood volume, and the cardiac output. How will be the adaptation of pregnancy can possibly cause long-term impact? How about the ventricular function, LT dilatation, myocardial fibrosis, or chances of arrhythmia? Will that occurs more frequent in patients after pregnancy? Let's look a few evidences. This study, including 13 pregnant women, compared with 26 non-parous TOF patients. They're using MRI to define the right ventricular volume before pregnancy and years after pregnancy. They found that in pregnant women, they have personal high rate of RV volume increase compared to those with non-parous patient. but the RV ejection fraction not changed significantly. Another study also using MRI, they found that after pregnancy, there's no change of RV volume, aortic dimension, and exercise data long-term after pregnancy. But they found a small increase of LV stroke volume index, but you can notice that the change is very small in pregnancy group. Another study using cardiac echo to monitor the change of ventricular strength, LV function before, during, and after pregnancy. They found that the LV longitudinal strength increased during pregnancy, but it recovered postpartum. And then there's no significant change of LV circumferential strength. This change of LV longitudinal strength during pregnancy may be due to the need of cardiac adaptation during pregnancy. Another study compared pregnant women and the non-pregnant patient using MRI. They showed in the long term, there is no increase of myocardial fibrosis marker and PR after pregnancy. But the patient experienced pregnancy with higher LV mass index and lower RV ejection fraction. But you can see the difference is not very much. What about the ventricular arrhythmia? Is that happen a lot in long-term after pregnancy? The answer is yes. In this study, if the non-parous woman, the chance of ventricular arrhythmia is very low. However, it increased with odds ratio about 13. Long-term after pregnancy, the chance of ventricular arrhythmia increased a lot. So in summary, the evidence about the long-term impact of pregnancy in repair TOF, regardless ventricular function, aortic dilation, or myocardial fibrosis, there's no significant long-term impact. However, as we mentioned, the ventricular arrhythmia increased a lot after pregnancy. And what is the impact of pulmonary valve replacement after the pregnancy outcome? They compared the pregnancy outcome between the woman with previous PVR or without PVR. They found that there is no difference in maternal cardiac, obstetric, or offspring outcome. However, the woman without PVR showed significant RV volume progression than those without PVR. So the PVR before pregnancy may have a protection effect to prevent the further RV progression after pregnancy. And another interesting paper is about the effect of pulmonary regurgitation for the fetal growth. They study include the 57 repair TOF and the 18 patients with PS. They found that maternal severe pulmonary insufficiency is associated with higher risk of baby with low birth weight. If the patient had severe or moderate to severe pulmonary insufficiency, they may have a lower newborn baby with lower birth weight. So the presence of pulmonary insufficiency can cause the abnormal uteral placental flow, and therefore to affect the growth of the fetus. Then what is the recommendations before pregnancy in repair TOF? For those with significant PR, we may consider PVR if the criteria met. For the significant PS patient, such as the pressure gradient above 50% or the RB temperature above 75 millimeter mercury. We all know that the obstruction will become more evident during pregnancy. So we will advise to relieve the pressure difference. For those with LT diameter less than 5.57 centimeter, the risk is generally low. And we have to pay attention about the ventricular dysfunction, both RV and LV before pregnancy. For those rare cases with pulmonary artery hypertension, especially for those with pulmonary atresia, we should be avoid pregnancy. Then we have to review the current cardiac medication such as ACI. We have to quit it before pregnancy. And we should perform cardiopulmonary exercise tests for functional assessment and detection for possible heart failure or arrhythmia. And we should consider genetic evaluation before pregnancy. We all know that the genetic component of tetrafalo is rather complicated. For the syndromic TOF, the identification is relatively easier. However, there are some polymerase mutations cause non-syndromic TOF. So early genetic consultation before pregnancy is very important for such cases. What about the care during and pregnancy and the labor? We have to give the multidisciplinary team and perform fetal echocardiogram at the gestation age of 16 to 20 weeks. And during pregnancy, we have to give them periodic assessment for possible heart failure and arrhythmias. And we prefer vaginal delivery unless obstetric reasons. In case of CS, prophylactic antibiotics should be given to prevent endocarditis. And we should give EKG monitor during labor for patients with history of arrhythmias and observation for 12 to 24 hours postpartum. In summary, in women with good ventricular function without significant hemodynamic residual, pregnancy is usually with low maternal risk, but with increased offspring risks, such as small for gestation and prematurity. Pregnancy may increase the occurrence of ventricular arrhythmias. Before pregnancy, we have to correct the significant hemodynamic residual, and the arrhythmia and the heart failure evaluation is recommended. PVR may prevent future RV progression and enhance fetal growth, and cause multiple possible heart failure and arrhythmia during pregnancy. Thank you for your attention. We will host the third ACHD symposium in this May in Taiwan. Welcome everyone to come to join our symposium. Thank you very much.
Thank you very much, Dr. Liu. That was a very nice overview. I'm very happy to take questions, but I wonder if I could ask you two things to start with. The first question I have is about the suggestion that maybe ventricular arrhythmia for these women in the longer term is more common. And I'm just interested in why you think that is and whether that should change our strategy when we talk to these women before pregnancy.
Yes, we may be aware of the ventricular arrhythmia more aggressive, and that we have to discuss with this issue with the TOF patients. This may increase the risk, but maybe not immediate postpartum or during pregnancy. It's a long-term issue. So we have to discuss it with our patients and watch out the possible appearance of ventricular arrhythmia after delivery of the newborn.
Do you think that, yeah, I guess I'm wondering, do you think this might occur because of the volume load and more stretch to the ventricle, or why do you think this occurs?
Yes, I think the volume and the cardiac output overload during the pregnancy may possibly have the chance of increase of arrhythmia.
Okay, so there are some other questions coming in. Dr. Del Rosario would like you to explain further regarding ventricular dysfunction in tetralogy and pregnancy. What are the things we should be considering?
Now we are using more the MRI to evaluate the ventricular function, including RV function and the LV function. And another helpful tool is the check of the NT-proBNP level. And we also use cardiopulmonary exercise tests to evaluate the overall function of these patients. So I suggest multi-modality to find the possible presence of heart failure.
Okay, thank you. And Dr. Leong says, great talk. And he says, patients with tetralogy generally have severely dilated aorta. Are there any reports of dissection during pregnancy? Should we use a much higher cutoff in these tetralogy patients for dilated aortic root? I'm assuming that means for surgery, or should we be sticking to the bicuspid aortic valve numbers?
Yes, according to the reference, there is very rare report of dissection during or after pregnancy in report tetralogy follow patient. So currently, the suggestion of the cutoff point is similar as bicuspid aortic valve is 5.57 centimeter. If this is less than 5.5 centimeter, it's generally safe. But if the aortic dilatation above 5.5 centimeter, we may consider aortic graft before pregnancy.
Okay, thank you very much. That was a great talk. I think we're probably at time now, so we might hand over to the next speaker. Thank you very much for your talk.
Thank you.
Thank you. So I'm Pichan Lee from Taichung Veterans General Hospital. I'm the greatest pleasure to introduce the next speaker, Professor Chiu Sun-Nan. Professor Chiu is a very experienced electrophysiologist. He had performed many procedures concerning to the case ablation in adult congenital heart disease and device therapy. So today the topic is he will give us a topic is case sharing, the VT management in repaired tetralogy pilot. Professor Chiu, please.
Can you see my slide?
Yes, very clear.
Okay. Thank you for Dr. Lee's introduction. And here I will talk about a case of arrhythmia in repair of tetralogy of Fallot patients. This is a complex case, but not uncommon situation in this repair congenital heart disease patient. This 48-year-old male is a patient of TOF with pulmonary atresia. He received multiple surgery, including VT shunt at 15 years of age and the total correction with artery operation at 16 years of age. However, he had a VT attack at 32 years old. This is 60 years later after operation. And he received catheter operation for ventricular tachycardia in other hospital. And because at that time, the guidelines still suggest the ICD implantation for all the patients with VT in repair congenital heart disease patient. So he received also ICD implantation in 2019. However, the patient still complained about the right heart failure symptoms, including ascites, edema, and tachypnea. So he came to our hospital 1 year later. And during the OPD clinics, we found an ICD shock once in 2020 July. And the doctor prescribed atenolol, and he had no more arrhythmia attack. This is the initial ECG at our hospital. We can see atrial fibrillation and the normal acceptable ventricular rate. The QRS duration is around 116 milliseconds. And we performed a cardiac CT, which showed he had a right atrial appendage Jata pulse, and also a large left atrial appendage. This may mean the atrial fibrillation have some impact on his hemodynamics. We also performed the echocardiography and the cardiac acceleration. The data show the severe pulmonary regurgitation, high pulmonary artery pressure. The mean pulmonary pressure is around 30 mmHg, and also the RV dilatation and the small LPA. So he received the reduced right-sided operation with reduced right-sided operation and the pulmonary valve replacement and the pulmonary arterioplasty. It is worth noting that the surgeon didn't perform the cryomass for the atrial fibrillation, although we have told the surgeon try to do the cryomass. The surgeon said the adhesion of this case is too severe, and he spent a lot of time to do the adhesion analysis and dissect out the heart. Due to prolonged procedure time, he had no time to perform the mass operation. After operation, the heart function improved, but he had still complained intermittent palpitation, and because of no cryomass, so he still had the atrial fibrillation reason. Because of the subjective symptom persist, so we performed an electrophysiology study for this patient, and this is the baseline electrocardiogram. We can see the atrial fibrillation with the atrial cycle length around 140 to 169 milliseconds. And we performed the right heart mapping first. Because he had sustained arrhythmia, atrial fibrillation, so we do the complex signal mapping first, the cafe mapping, and it showed some complex signal at the Jata pulse eye appendage and near the coronary sinus os, and some at the posterior surface of the right atrium. So we do the cafe operation of near the CSOs and do the right atrial appendage orifice isolation. After this procedure, there is no cafe noted at the right atrium. However, the atrial fibrillation persists, and we try to do the transeptal puncture under the ICE guidance, and then we do the pulmonary vein isolation, the right pulmonary vein, and the left pulmonary vein. However, after the pulmonary vein isolation, we try to do the cafe mapping also, and we can see there is still some cafe noted at the large atrial appendage, and also the LA anterior wall. The LA anterior wall is just adjacent to the Jata pulse eye appendage. So we do the operation in these two parts. And we didn't do the left atrial orifice isolation because it may cause some LA thrombus and may cause a later stroke. So we just do the cafe ablation. After ablation, we perform DC cardioversion and normal signs resume. And in the OPD, we gave him some sildenafil for pulmonary hypertension control, some Cyanide and prazrenolone for the heart failure control, Lysiana for the anticoagulation because he had atrial arrhythmia, and clotadone also for the arrhythmia control. However, he still complained about intermittent palpitation and chest tightness 2 months later. The ECG showed atrial flutter with a longer cycle length, and he admitted for cardioversion first, but it recurs very soon. So we perform the electrophysiology study. At the electrophysiology study at baseline, the intracardiac electrogram showed an atrial flutter with a tachycardia cycle length around 290 milliseconds. And during mapping, there is another atrial flutter with a shorter cycle length, 251. And after we complete the right atrial mapping, we can see this is an activation mapping. We can see a double loop reentry around the trachea valve and also an eye appendage. This is a population map. We can see there is a dual loop reentry, some slow conduction zone here and here, but we try to avoid the common pathway here. And this is a voltage mapping. There's many scar at the right eye anterior wall and the SVC and the eye appendage junction. After the ablation of this part, and we also do the carbotricuspid isthmus ablation. In our CAS lab, in our EP lab, we use totally zero follow mapping for and the ablation for all the cases, even when patient had a complex congenital heart disease. However, in this case, with the intracardiac device and this, we still use fluoroscopy to make sure the IF energy didn't damage the device leads. In this case, we can see during the carbotricuspid isthmus ablation, the ablation site is very near the ICD lead. So we have to be very careful in this kind of cases. After the atrial flutter ablation, the stone sinus resume. However, during the EP induction, we induce another ectopic atrial tachycardia with a longer cycle length from the eye roof. This is near the junction of the eye appendage and SVC. So this is a propagation map. There is a focus at the eye near the eye appendage site. So we do the ablation at this point. After ablation, the normal sinus resume. He then lived an uneventful course for the late 1 year, for around 1 more year. However, in 2021, August and October, he received a COVID vaccine using the Medigen vaccine. This is a protein-based vaccine from our country. And he had an ICD stone with totally 19 times of ICD shock. And he also complained about palpitation and dyspnea. The ICD interrogation showed a ventricular tachycardia. And the EKG also showed a ventricular tachycardia. So we do the electrophysiology study again, and we can easily induce a VT by ventricular extra stimulation. And the tachycardia cycle length is 2020 milliseconds. And the ECG is similar to the clinical VT. And we try to map the RV first, because in previous study, we all know that in the repair tetralogy of follow patients, the common isthmus is VSD to RVOT, VSD to trachea valve, and the RVOT to RVOT incision and to trachea valve. And however, when we map in the right ventricle, we didn't see any reentry circuit here, and the mapping cycle length is also around 60% of the total tachycardia cycle length. So the true substrate may be not in the RV. This is a propagation map. We can see the mapping cycle length at the right ventricle is around 200 milliseconds, and the tachycardia cycle length is 322. So we perform the LV mapping. At the LV propagation map, we can see the reentry tachycardia around the VSD patch area, and with two slow conduction zones here and here. This is the activation map. We can see a reentry circuit, and the tachycardia cycle length is, the mapping cycle length is nearly 100% of the ventricular tachycardia cyclins. And this is a LV and the RV combination. So we perform the ablation here first, and because there is still another slow conduction zone here, so we try to ablation here. However, when energy applied, there is the transient AV block, so we immediately cease the energy and the normal sinus resume. After this ablation, he then followed for more than 1 year, and there is no ICD shock now, and no VT events detected at the ICD, and no more SVT or palpitation attack in this 1 year. And he got COVID in May this year, and there is no arrhythmia attack. Now, beta blocker was continued, and he tried to taper a cortisone later. So in this complex case, we know the multiple atrial arrhythmia is very common. It is a paper from 2010, and we already know that the multiple atrial arrhythmia is very common in this repaired congenital heart disease patient. And in the Boston data, the 5-year arrhythmia-free survival rate is only 50%, and many of patients had multiple arrhythmia. That means the recurrence is not at the same focus, but at the other arrhythmia substrate. And the atrial fibrillation is another important issue and a common day problem. In previous study, they found in a younger age, the ART atrial flutter is more common, or AT is more common. However, when the patient got older, the atrial fibrillation has become an important issue. However, how to avoid this atrial fibrillation we still have no consensus yet. And many of it is a large study from the multi-center from United States and the European countries. And they perform the PV isolation in most of the cases. LA line, CAFE, and the CTI ablation in around 20 to 40%. However, the complete success rate, that means we can totally discontinue the arrhythmia drug, is only 45%. And the partial success rate, this means no arrhythmia attack by anti-arrhythmia medication is still needed in 20%. So totally 60% of the cases may have no arrhythmia attack. And for the ventricular arrhythmia, in previous consensus, they also suggest the ICD implementation for a patient with ventricular tachycardia. However, in the recent guideline in the Heart Rhythm Society, they suggest for a patient with normal heart function, no residual problem, or residual problem has corrected, and no pulmonary VT in a simple or moderate congenital heart disease, they suggest ablation first. And if there is a arrhythmia attack recur, then they suggest the ICD implantation. However, in our previous study, we suggest the replacement heterogeneity may be an important issue, so the patient may have another arrhythmia recurrence in these cases. So if in this case, if the patient didn't receive the ICD implantation, he may suffer ICD stone and then may have a poor outcome in the ICD stone. So we still, in our center, we still perform the ICD implantation for all the repair of the charge of patient with substrate VT and with substrate VT to prevent endocardial death. Thank you for your attention. Okay.
Thank you, Professor Cho. It's a very complicated and a very difficult case for the EP man. So my question is for the atrial tachyarrhythmias. So what are your mapping and ablation strategy for the atrial fibrillation in repaired TOF? Because it's very difficult. In addition to the triggered, so what kind of substrates will you just perform the ablation?
Okay, I think this is a very difficult issue and still no consensus issue. And I think, although we may think the right heart is the most important substrate for the atrial fibrillation in congenital heart disease, because the right heart dilatation, right atrial dilatation. However, most of the time we still perform the pulmonary vein isolation because we can see the atrial fibrillation increase with older age. So the pulmonary vein substrate is still an important issue in this patient. So we still will perform the pulmonary vein isolation. However, in addition to pulmonary vein isolation, what kind of a procedure is needed? We still didn't know the most perfect ablation procedure in this patient. So we perform a cafe mapping in some of the patient. In some kind of a patient, if there is trigger, a beautiful trigger, we may ablation this part. However, in most of the patients, like these cases, there is a persistent atrial fibrillation, so we may not to after the ablation, in these cases we didn't induce another atrial fibrillation, so we didn't know the actual trigger of these cases. In some of the cases, they suggest the CS or CS common sinus or SVC may be an important trigger. In these cases, I think the enlarged eye and the LA appendage may be an important focus. So we try to perform the cafe ablation and the right atrial appendage orifice isolation in this case.
So if the patient with the persistent LSVC, will you just perform the CS Austin trigger the isolation?
I think it may be important if the patient have a PLSVC, because the PLSVC will dilate when the eye pressure increase. So that may be an important trigger. But we have tried to perform the CS mapping in one of the cases. But however, when we introduce the mapping catheter, there is almost no signal in this patient. So I think maybe the variation is very large, patient to depend on every patient. So so maybe precision medicine for case by case is very important.
Yes. So concerning to the ventricular tachyarrhythmias, you see it's a very rare, because usually it's the substrate is located at the right ventricle, but in this case, the circuit is the left ventricle. So it's very rare actually. So what kind of patient will you just suggest? Maybe it's the circuit, the substrate is right side, left side, sorry.
Yeah, because we perform the eye mapping and we didn't see any substrate, and the mapping cycle is only nearly around 60% of the tachycardia cycle days. So because in usual we didn't perform the left side mapping, but in these cases we didn't see any possible substrate, so we then do the left side mapping. And initial mapping we see a very late signal in the LVOT, so we then perform the detailed mapping for the LV. However, to perform LV mapping is not very easy for these cases, because there is some AV blocker in this kind of cases. When we perform the mapping at the conduction system near the LV VSD area, so I think in our theory we suggest that reparation heterogeneity is an important component for the ventricular tachycardia in congenital heart disease patient. So when the patient has a reparation heterogeneity, when the patient had another obstacle of the natural barrier or the incision scar, it is very easy to induce the reentry ventricular tachycardia.
Yes. So for the bradyarrhythmias, maybe this is not your talk today, but I'm very interested for the conduction system pacing. So for this case, in repaired tetralogy load, do you think a conduction pacing is good, or so? What's your opinion?
I think conduction system pacing may be a future for the congenital heart disease, because we know the RBBB, the cardiac insynchrony is very common for the congenital heart disease, because they have the right bundle branch blocker in most of the cases, and LB left bundle branch blocker in some of the cases. So if the patient have a complete block, and the patient, if we just perform the conventional pacemaker, then we may aggravate the cardiac dysynchrony. However, there is some paper for the repair tetrahedral valve for the, with complete AV block. And I know in one paper, he performed the RV pacing only because he had a right bundle, the patient had a right bundle branch block. He performed right ventricle pacing, and it can correct his right bundle branch block. So, and in our case, we also had one case of the repair tetrahedral valve right heart failure. After PVR, the patient cannot intubation because he had a very severe heart failure symptom. QRS duration is more than 300 milliseconds. It is a very wide case. And because he had a AV block, so we the surgeon had the lead in the RV, so we try to perform the RV pacing. And the QRS shortened to around 180 dramatically, and the patient can intubation. So I think in some cases, simple right heart pacing may also is acceptable, but maybe the conduction pacing is better. This is a unknown issue. So we think there is many things we still didn't know, and there is more studies needed to try to solve this problem.
Yes, thank you. So at least I'm very, congratulations, because it's very difficult to convince patients to perform so many times of procedure. So I think the relationship should be very, very good. Okay, thank you. So because of time is limited, so let's proceed to the closing remark. Thank you. Thank you, Professor Chiu. Thank you.
Thank you, Professor, and Taiwan Secretariat of APPCS 2022. That was a great presentation with great speakers and very engaging moderators. And this is the culmination of the TOF webinar series, starting from fetus and now a lot of problems in adults with arrhythmia. So I am Dr. Gagnon, the closer for this last TOF webinar, and the overall chair for this coming Congress, APPCS Congress in February 23, 25, 23, with our command center at Radisson Blu, Cebu. Okay. So before I officially end this TOF webinar series, I have to present some of our preparations for this APPCS Congress. Okay. I want to screen share. So as I mentioned, our Congress in February 23, 25, theme Innovations and Solutions to Complex Cardiac Problems, the 9th APPCS Congress. So we have prepared a lot. This is the overview of the Congress. It will be 3 days with 4 virtual ballrooms, track 1, 2, 3 for symposium, and track 4 for live interventional procedures on day 1 and research presentations on day 2 and 3. We are preparing 33 simultaneous symposia with 99 scientific lectures and more than 100 speakers. We also prepared 6 plenary talks, 2 talks per day, and 2 debates for day 1 and day 2. And I already mentioned 4 live cases. This is LifeTech Live on day 1. That's February 23, because LifeTech sponsored all the LifeTech live cases. 2 cases in the morning of the 23rd and 2 cases in the afternoon. All this is live interventional procedures will be done at Philippine Heart Center and live streamed to all APPCS countries and also fed to our command center at Cebu City. So I also mentioned 1 research track. We already have the finalist. So this involves around 26 CME hours and distinguished faculty all over. So this is the international roster of our Congress faculty. So it's actually a composition of Asian, European, Australian, and US speakers, faculty. So in a nutshell, this is our scientific program, day 1, complete with time and speakers. Day 2 and day 3, we have 2 social events, the welcome dinner on February 22 and the fellowship on February 24th and closing ceremony on February 25th. This is our Congress website. This is very searchable in Google, okay? And also our official website, okay? APPCS 2023, searchable and clickable. So please check this out and register to our upcoming APPCS Congress 2023, okay? And this is how you click, you register, okay? By clicking. You can also register, and we are also available in Facebook, Instagram, Twitter, or you can use this QR code to register. So I will be endorsing all of these materials to the Taiwan Secretariat, hopefully disseminating all of this to our APPCS country members. Okay, so again, this is our brochure. Okay, and if you notice, for those who will be coming physically, although this is an purely virtual Congress, we are still offering a physical attendance from February 23 to 25. And one of the reasons is we might be offering some of the tourist destinations. And on the right picture, you can see the aerial view of great white sharks, the whale sharks. This is one of the attraction, one of the tourist attraction in Cebu, in Oslo, Cebu. Okay, so we call it Butanding in our local dialect. So once again, I would like to thank Taiwan APPCS Secretariat for this very wonderful presentation. And this will not stop here, although this will be, as mentioned by Professor Joko, this will be the last of their series. APPCS Philippines from 2023 to 2025, we will be the revolving secretariat. We will continue this webinar, okay? And I think the same format, APPCS Academy. So at this point, I would like to ask all the speakers and moderators to open the cameras for a photo op. Professor Joko, Dr. Claire, Dr. P. Cheng Lee, Dr. Mi Wan, Dr. Shinanchu, that was great. Congratulations to everybody, and especially congratulations to Taiwan, Dr. Mei Wan, Dr. Chon Wei Lu, and I understand Dr. Koichiro, Professor Koichiro Niwa is not here, okay, online, okay. Thank you for the photo op.
Yeah.
Professor Joko, last word.
Yeah. Thank you very much for your kind introduction to APPCS 2023. I hope everyone can attend virtually or in person. So I think this education forum should continue continuously in this region, and we hope that there are more people were involved in ACHD care. So I think this is, we want to promote the ACHD care in this region. So thank you all. Thank you very much for your kind support to this society. So thank you, everyone.
Thank
So
you.
can we take a photo?
Sure, and Happy New Year.
Happy New Year.
Yeah.
Happy
Thank
New
you.
Year.
Thank you. Take care.
Take
Take
care.
Take
care.
care. Keep safe.
See you soon.
Yeah.
Bye-bye.
See you soon.
Bye-bye.
See you.